A very good afternoon, one and all. The brave slash in a new context. So we've all heard about the old context of brave slash used by Anwar's big bubble technique in dark surgery, but I bring to you a new context. Spontaneous detachment of the Descemet's membrane of a PKP graft is a very rare entity and is reported only in 6 cases so far before our case. Large or subtotal graft Descemet's membrane detachment can be difficult to manage and may fail despite many attempts. Describing here a technique of draining the pre-descemetic fluid with the help of a venting incision to achieve successful descemetopexy. The premise being a 29-year-old male with bilateral PMD suffered acute hydrops in 1992. He underwent a PKP in right eye in 1993 and maintained a clear graft with 612 vision till 2019. And in 2019, he developed a sudden onset fall of vision after 27 years. This mimicked an acute graft rejection. Even a pigment line was seen. Other eye, PMD. But something was amiss. So when we evaluated him thoroughly and dehydrated the cornea, deterged the cornea with topical glycerine, we found the culprit was a Descemet's membrane detachment, which was spontaneous, and this was corroborated with anterior segment OCT. What we did here was a supradescemetic venting incision. This is a graphical presentation. You see the graft there. And this is the DMD spanning the width of the entire graft. We made a venting incision through the stroma into the interface between the Descemet's membrane, and instantly the fluid starts egressing. The DMD starts flattening. Then we make a paracentesis after this step and introduce gas or air as is the technique that may demand depending upon the surgeon's preference. And this helps to tamponade the Descemet's membrane. Here you see the post-operative pictures immediate, where you see the arrow showing the venting incision and the arrowheads showing the pigment line, which was in fact the pigments accumulated at the junction between the attached and the detached Descemet's membrane. So here is another case. This was actually a post-cataract surgery DMD, and this was taken after surgery, after failed descemetopexy. So I recommend removal of the epithelium before making this venting incision at the point of maximum detachment. This was a non-planar detachment, more than 1.3 millimeters. And when you make the venting incision, this is in slow motion. So you see instant egress of fluid. Then you make the paracentesis, not before making the venting incision, so that the DMD is maximally detached when you're making the venting incision. Then you introduce air into the anterior chamber, give a nice tight fill, raise the IOP really well, like you do in endothelial keratoplasty, like in DMEC. Raise the IOP very well, and then you start milking the area of the venting incision. You will see beautifully how the fluid drains through the venting incision. This can be used in long-standing Descemet's membrane detachment. The PKP patient that I talked about was a 10-week-old Descemet's membrane detachment and attached really well. The quality of the fluid may become viscous over a period of time, and this will help the Descemet's membrane to settle even after a prolonged period. So you can save the patient from going in for an endothelial keratoplasty. Here you see a 1.3 mm, this is a non-planar detachment, 1.3 millimeter detachment, and settles very well after this technique. The indications apart from this could be failed DM reposition, DMD in spontaneous or otherwise in a graft patient, and of course in DSEC detachments, if there are focal clefts after DMEC surgery, or even a double anterior chamber post a dark surgery. So the conclusion being that supradescemetic venting incision is a simple but significant addition to the surgical armamentarium of management of Descemet's membrane detachment, which could be a nightmare in a very well done intraocular surgery, especially in long-standing ones or those that have failed routine tamponading methods. Thank you. These are my references.
Thank you, Dr. Seema. Dr. Mohan Rajan, sir, your comments, please.
Venting incisions were there earlier also. No?
So yes, sir. The venting incisions that were there earlier, they were described specifically in situations in DSEC surgery. When you make the venting incision after you score the endothelium, then you make a full thickness stromal incision. And then you introduce the graft, and then you inflate. So actually when you're making the incision, it is through and through the stroma, and the endothelium is not there. Here what we are doing is you're making the venting incision when the Descemet's membrane is in fact there. So when you see that the fluid is vented out of the incision, there is no gas draining out of the incision, which means that there is no full thickness incision through the Descemet's membrane. It is into the interface. That is how it is different from.
Yeah.
So yes, that is why what we recommend is going for non-planar or very long-standing detachments which have failed multiple attempts. Non-planar DMD meaning the Descemet's membrane detachment on ASOCT is 1 millimeter at least away. So when you go through the interface, you are at very low risk of actually, with the fluid kind of drains, not immediately. Like in big bubble DALK, you'll have, as soon as you make it, the air, there is air in that. Here there is fluid. And the fluid might have changed in texture over a period of time. What happens in long-standing cases is the area where the Descemet's membrane break would have been there would have been fibrosed also. So for that fluid to come out of the break of the Descemet's membrane area, if it's fibrosed, it will not settle well. So here we are creating an additional channel for the fluid to drain.
You used a 11 number blade?
No, I've used a 50 number side port incision.
Isn't something else better than this? This appeared too big. Like a MVR, only the tip of the MVR, which is much sharper, faster.
Maybe a calibrated blade.
Or something. You got, I mean, what I'm trying to say, that this appeared to be too large.
And OCT guided also.
So yeah, OCT guided is always an additional factor. If you have the this thing of having intraoperative OCT, that is a factor that can be taken in. But as I have noticed while doing these cases, a very small incision is, because it's kind of a self-sealing incision, it's not sufficient enough. I have tried it even with something like a small needle kind of thing, but it's not sufficient enough. When we have that significant amount of incision, only then the fluid will start draining with pressure. That is the milking technique.
And even in DSEC, you prefer using those kind of blades?
Sorry? Hey, that's what I'm.
No, but in DSEC also, we prefer using these kind of blades
Side
rather
port
than
blades.
pointed needles, because like she said, you have to pass through a lot of stroma before you reach.
That stroma doesn't allow the thing to instantly egress. It's like a valvular seal. So if you have a very small incision, it doesn't drain well enough. You need a calibrated again, sir. We'll have to decide that. Yes, sir. That's
Yes.
yes. Probably, and also we'll have to know at which area we are going in the cornea and what is the stromal thickness of that area. We cannot take the stromal thickness of a regular cornea as a calibrated. We'll have to,
we'll have to do that.
the OCT.
So it
that
should be an
part,
adjustable,
smart.
calibrated.
Exactly, you'll have
So
to have something which
next
is
time we hope you'll come with the innovation
No,
with that also.
it's available in the market. You get RK knives,
Yeah,
which
that
are
of course you do.
calibrated. So you can use an RK knife,
Yeah.
which are
We'll take
diamond
that.
bladed knives. And you
Yes.
Sure. Thank you, sir.
On Arco 8, yeah.
Yeah,
Exactly.
also.
Yes, thank you so much, Dr.